lectures in front of my own friends and my own colleagues, my batchmates. So this is a very, very emotional moment. I thank the organizers for having me here. So while we are down this memory lane, let me take you back to your classrooms and probably talk to you on one of the topics which then was not just complicated but also very boring. I'll try and reinvent the whole wheel for you over here. So in our routine evaluations of the patients, we do vision refraction, IOP, color vision, pupil, anterior posterior segments, and then we give the patient the diagnosis. Having missed out something over here. When we talk of binocular vision, for most of us, it is an expanded visual field. But is that all? No. We need to look beyond and assess the stereopsis, accommodation, fusional vergences, saccades, pursuits. As horribly complicated as this sounds, unfortunately it forms a very, very important part of our visual experience. So vision doesn't get over with the 2020 chart reading or recording of 2020. Vision is actually that plus this. So it is 1 plus 1 giving you binocular vision of both eyes. So why is it so relevant? As I said, it is relevant in today's world more than it ever was, because we see patients with asthenopic symptoms today. I didn't see them 15, 20 years back. We are doing a lot more refractive surgery, we have LASIK, phakic implants, we are doing a cataract surgery, which is no more just a cataract surgery. Even our cataract surgery today is a refractive surgery. We have amblyopes, we have children with special needs. I'll have a special word for these special children and what we as clinicians can do to change their world. So in our clinics, a binocular vision assessment would involve grading the heterophorias, the accommodative facility, fusional vergences, saccades, pursuits, stereopsis, and this is absolutely a headache. You can't do this in a busy clinic. So this is a neglected science and it's forgotten. And why do we choose to forget it? Because you see this armamentarium, it is a lot, it's cumbersome. And you require a very high level of proficiency to carry out the test. Forget about the high intelligence that the patient needs to be able to do these tests. So what is the requirement? What is the need of the hour? The need of the hour probably is to have orthoptics made easy on a digital platform. Fast, the results have to be reliable, and not only do we need the diagnostic, but we also need treatment for it. And so in Binocs, we have a first of all, what is Binocs? Binocs is a software program, it's SaaS-based, and this program is on the digital platform, and it is got different parts to it. One of it is known as the Binoptics. Now, Binoptics deals with this fast, reliable diagnosis and treatment of binocular vision dysfunctions. So, where in our practice can we apply this? Today, 1 out of every 3 patients that is coming in our routine OPD is coming with symptoms of asthenopia or computer vision syndrome, where they are having issues because they are peering into the screen throughout the day. And many of them continue peering even into the late nights. Now we know that 3 billion people are using internet throughout the world, and 50 to 70% of these people are on a screen for at least 3 hours or more. So if people are on the screen for more than 3 hours, they are going to experience symptoms of the digital eye strain. Okay. So we are looking at a population of about 400 million with symptoms of CS. Okay. Now, in my practice, I like to divide the symptoms of computer vision into two. One are the external symptoms, where the patient comes with redness, watering, gritty sensation, foreign body sensation. These are symptoms related to dry eye. And then the patient comes with symptoms which are internal symptoms, wherein the patient
said is we can pick these up patients early, and then we can preoperatively assess them, just like what we do dry eye management, and then again attend to them once the cataracts are done, getting a better outcome for the patient. So that's what I like to say. Well presented. Something really. I think we have not been thinking about it as much as we should, and I think it's a good point raised today. Something with last time I really remember it was Professor Gurudev Kamath and Professor C.R. Kamath doing his. You remember the first initial screen talks that Prof had done? That was the first time I attended KMC in my first week when I landed up in Mangalore. And one of the first things that Professor C.R. Kamath did was his elaborated couple of talks in those days. And obviously I'm not going to be able to replicate what he said all the time, but thereafter was taken up by Dr. MMK and Dr. Gurudev Kamath as well. And I think it's a good, very pertinent issue raised today. Anything from your side?
Thank you, Dr. Sonia, for this wonderful presentation. It does seem like a groundbreaking treatment for adult and myopia. I have one question. You said you're the eldest person you treated was 60 years old. So how many other 80 plus years old are there in your study group? And how was the response?
18 plus.
Adult age group.
2 lines more, which is also huge for it, but definitely stereopsis does come.
A little corollary to this is that what is required for the patient is having a bilateral focal fixation, and any kind of a phoria is a contraindication for this and getting good results. So it should be orthophoric, and there should be no eccentric fixation.
Yes.
Even dents and lie-offs, sometimes instead of getting 30 sessions, we go even up to 60 or 70 sessions. They do land up somewhere between 624 to 618. They may not touch 6 months.
First of all, congratulations on developing something so wonderful. But I have a question. They had come to me when I was in Bangalore.
And my talk is intended for the backbenchers. I've been one here, so I don't intend to speak for the frontbenchers. But you should. The take-home message I would take for this talk amongst you would be there have to be 2 eyes for you to be even thinking of multifocality. So all of us will be jumping on cataracts once we pass our PGs. I interacted with them yesterday. Everybody wanted to do cataracts. But remember, it is only in a 2-eyed patient that you will even think of implanting a multifocal. Okay, so if you base your practice on that, I think there's basics if you think of, it will be good. So my talk, I decided to talk on managing presbyopia post-cataract surgery. A lot of people do not want to use glasses even after they've had cataract surgery. So the main focus of the surgeons as well as the IOL manufacturers is how to make them spectacle free. I wouldn't call them spectacle free. I always counsel them to be not spectacle dependent, to reduce your dependence on spectacles. So there are an armamentarium of lenses which are available to us, and we can use each one of those lenses to make them, to reduce their dependence on spectacles. The age-old monofocal lenses, multifocal lenses. For a small amount of time, there are accommodative lenses which were available, which did not really do very well. And the latest, what is available to us now, the technology is EDOF lenses. So I am just trying to lay bare open the EDOF lenses in front of all our eyes. So with monofocal lenses, we can still target them, facilitating to the patients, especially those with an active lifestyle. those with night driving, so you really have to choose your lenses, your patients properly to be implanting multifocal lenses.
It's in the interest of the industries that they sell more of the multifocal implants, but yes, you need to know that. So I've got a video that I've prepared by myself. So each and every of my patients watch my video. It's about a 15-minute presentation where I'm speaking to the patient there, and I try to explain to them what are the options now. So basically I divide into mini monovision or monofocal vision and multifocal vision. So I try to talk mini monovision because it's still very useful, except those cases where they've got exotropia. Those are the ones you definitely don't want to do mini monovision, but for the, in the good cases, it's still a very reasonable option to aim slightly myopic in the non-dominant eye. So you could be very careful to select the dominant eye. The EDOF lenses in my hands, I'm sorry, hasn't worked too well. I've tried everything, including Clarion and VVT Clarion. And it's a very beautiful gadget to see how it enters the eye and how it unfolds. Dramatic picture, but the thing is, in my hands, outcomes are still modest. If a patient really wants to be spectacle independent, in my option, the only option is in what I do with my eyes. In your own experiences.
For myopes, for uniocular patients, and for young patients who are driving, I will prefer to refer them to another person to be doing a multifocal and explanting them myself later on.
Yes, very true. Otherwise, too much yet. Yes.
These people, have you done a lot of explants? And if you do explants, what do you do then?
So then I would have talked to the patient and say, see, you've had a multifocal implant and that's what you wanted in the first place, but you've come out very unhappy. Sorry, I won't touch the second eye until I explant the one that they're not happy with. Okay. But the big problem is, you see, that summation effect kicks in when both eyes are implanted. That's what you said. If you're going to be putting a multifocal implant, you've got to plan for bilateral multifocality. But the situation is, you've done the first eye, patient comes to me the next day, yes, I'm seeing 6-7.5 distance, but I'm just not happy. I've got this constant blur. So in that case, I do explant the eye before I touch the second eye. And put a monofocal monofocal. Give them the option of monofocal, saying very well that this is your final option. The only situation where I put the IC8s are post-corneal refractive surgeries, or not the LASIKs, but post-corneal RKs, radial keratoconus eyes. In those traumatic corneas with corneal scars, the IC8 really has worked magically. There's been a patient of mine where I've done IOS, bit of trial and error, so you can't, but the only thing is make sure you, whatever you do, make sure you always undersell. Say that, ho sakta hai ki aapko result na mile. So at least if they understand that, then it'll make a lot of difference.
What about patients that so existent?
Treating these inflammatory conditions, infective conditions, quite different to deal with. But inflammatory disease is quite difficult to treat. So in our settings, the important thing is to identify the source of inflammation. Just like infections, you need to find the exact reason why this comes and how do you control it. And also that us not controlling, as you know, this can be lifelong, so prevent the damage from that and preserve the vision in the long term. And also the effect of the systemic disease, that's what you're encountering, so you need to limit that effect on the systemic disease, on the condition of the eye, which is the long term. So I'll just give you some pictures if you look at those, and I'll just briefly go through what treatments normally do. You're very familiar looking at these conditions. This is one of those patients with idiopathic vasculitis. But if you look at the picture on the other side, it's a Takayashu. I'm sure some of you are very familiar. Some of you may not be coming across that as a juniors. There are different forms of vasculitis you come across. So if you do an angiogram, carefully watch out for what pictures or you would see with. I quickly go through some pictures. So this is, again, benefit of juniors. This is Behcet's bilateral presentation. Presented with corn fingers in the other eye. I think 6, 18 something in the side. This is post-treatment.
Open communication.
Probably no. I think using steroid responders are in the population. You tend to get about 20% of the high steroid responders. Half the time you may not know them, but good indications that those patients using a topical steroid, those showing the signs of high steroid response, probably avoid those patients. But however, if it is unilateral disease, you don't want to give the patient systemic therapy, you can explain to the patient, well, this is the situation. You've got to be prepared for steroid surgery such as prior or you. So sometimes I use a younger patient, for example, those who have intolerance, intolerant, they give them intraocular implants, but I prefer the surgeon. So I work closely with glaucoma surgeons. We operate them early. They don't wait for the visual field damage to happen. So any pressure spikes, we just go and operate.
So in that sense, don't you think that the topical and oral steroids we can stop immediately when we see the unitaries in IOP, but with the implants and then periocular injections?
Yeah, I think my practice is based on what I see. For example, they just have inflammatory signs, trying to control them somewhere as less invasive as we can. But the moment they develop macular edema, then you have to be more invasive, more aggressive. So use all the forms of available therapy. Whether you encounter cataract tomorrow or optic nerve damage, you've got to try and stop steroids. You mean talking about implants or? Yes, sir. So I think when you get a macular edema, unilateral disease, older patients can easily start giving. The younger patient, you have to be careful, obviously, considering the cataract. So when I inject this, when I see a macular edema, almost recurrent, may not be the first attempt, but if you treat it topically or oral steroids settle down, but you see a recurrence, just to be unilateral disease, I put no stress in it. Yeah. Thank you.
I resort back to my old teacher. No, sorry, I can't call it old teacher. Our old teaching is when I used to work with Dr. Jyotirmay Biswas in Mangalore. Everything is infective until you prove otherwise. So whenever a case of uveitis kind of walks in with 3+ flare, hypopia, first thing is you got to think this is an infective in the first place. Rule out that, and then you can attend to the rest. Because if it is an infective, then you've lost the case if you delay it. So that's what Dr. Jyotirmay Biswas used to teach us when I was at the Mangalore way back in 1995. And I think the same applies to what he says. So that's what we do. And of course, if it's infective, following blood test and chest X-ray and all those things we've done, and probably would like to involve an infectious disease specialist right away, because they are the ones that will guide us what antibiotics to use or what antivirals to give. So that's the first line. And then if it all comes negative, then I think we'll go into the conservative way. We manage initially with topical steroids, and if that doesn't work, then of course we're happy to add on oral steroids or periocular steroids, and if that still doesn't add, then probably involve rheumatologist.
He started his private ophthalmology practice in 1998 and set up Milne Eye Care Hospital. He practiced for 30 years and grew to a group practice of about 6 eye surgeons, 35 staff, and an average of 200 cataracts a month. He then sold the practice to the Agarwal Group, and he now works as director at Milne Eye Care at a unit of Dr. Agarwal's. His areas of specialization are multifocal IOLs, toric IOLs, and different.
Good afternoon, ladies and gentlemen. It's a flood of memories as we walk through the corridors of Mangalore Hospital and the front part of KMC Mangalore. Revisited the place where we did lots of things. Many things we should have done and many things we could not have done. It's good. So my topic is far less intellectual than Dr. Kumar's topic. What I'm going to do is, there are 2 parts in this topic. One is the quality of the practice, some guidelines which I share from our work at my place. And the second is business strategy of how to grow the practice. So what I'm going to do is going to spend 10-15 seconds per slide, run through them, and then start the presentation based on the interest of the audience. And I'd encourage you to raise your hand and stop me if you want me to go more detailed into any one particular subtopic. Can I have the lights on for the moment, please? So I have been doing multifocal OPD for the last 4 years, so I'm really out of touch with what actually is happening there at this surgeries. Now, I wanted to ask you, since we've had nice, interesting and guarded talks on multifocals, I'd like to request all of you with a raise of hands that tomorrow if you're having a cataract surgery, who will choose a multifocal lens as your first choice? Raise of hands please. 1, 2, 3, 4, 4.5? No, that went down. Okay. This is called the reality check. Okay? So we have the practicals and that. So just one or two comments on what Dr. had mentioned before. I think the secret to multifocals is absolutely accurate biometry. If you go wrong there, then the whole story starts. So only cataract surgery where you have a complication before the surgery starts. You got a wrong biometry and you don't know it. Anyway, so I think the EDOF lenses, the comment on that, the eye hands, which I think you were not so very happy with. I wouldn't go to the brands, but there are new technology EDOF lenses and we don't know the technology. The lines they draw on paper and bend all the rays of light against the laws of physics is for marketing. The light doesn't follow the research head of J&J or Zeiss or anything. He does what he does. But this much I can tell you. They won't share with us how they actually modify the service. It says, I don't know, I'm 30 old. It costs, see, the fees you pay to Zeiss is 40,000 per case or 35,000 per case, which is what you pay to the company. So it's like you buy your car and then you rent it also to give them a rent. You buy your house and you pay rent also. If you look at the bank loan you take on a 3 crore machine and do your math, it's substantial. Then you look at your AMC cost, it's very high. Then if you take cost to the referral fees because he has to get a lot of OPD, I think his left with almost nothing. So LASIK is something which any person who knows simple arithmetic would not touch. But to the pure pressure, I also have LASIK. Oh, I do, what's that, femto LASIK, blah, blah. They invest a lot of money. Banks are happy, Zeiss is happy. I don't think it's